and welcome everyone. I'm Beth Stewart, Director of the Texas Oral Health Coalition, and on behalf of the Coalition and our conference partners, the Texas Health Institute and the Texas Department of State Health Services Oral Health Improvement Program, I'd like to thank you for joining us for the second session of the 2020 Texas Oral Health Virtual Conference. I have a couple of housekeeping items to go over before we get started, but I'll make it brief. The recorded versions on the conference website are for edification only. I would like to now introduce Dr. Christina Murphy, Conference Planning Committee member and Professor of Nursing for the Women, Children, and Family Science Department of Texas A&M University Corpus Christi, to serve as moderator and introduce our first presenter. Dr. Murphy, the mic is yours.
Thank you, Beth. Welcome, everyone. We are very excited about our next presentation, Dental Considerations for Individuals with Autism, by Dr. Lyubov Slashcheva. Dr. Slashcheva works with Apple Tree Dental in the outpatient program to provide oral healthcare services to individuals with special access needs, including older adults, adults in treatment for substance use, and individuals with disabilities. As a public health researcher, she understands the broader determinants and political implications of individuals living with autism. And she is very passionate about advocating for improved oral health and overall well-being among vulnerable populations. Welcome, Dr. Slashcheva.
Thank you, Christina, for the introduction. I'm very pleased to be here, invited by the committee to present a topic like was introduced. I'm very passionate about. I'm not used to having people be interested in this topic. So our objectives today will be to talk about the epidemiology, so what is the prevalence and how has that changed of autism spectrum disorders in the context of neurodevelopmental and intellectual disabilities overall. And then understanding some of the challenges and best practices for providing dental care to these individuals within the context of our political and social structures that guide some of the ways in which dental care can be provided. And then interfused within the presentation, you'll see that I want to emphasize the importance of interprofessional practice as the way that we're able to provide optimal care to this population. A little bit of a primer here on intellectual and developmental disabilities, and oftentimes there's this other term, neurodevelopmental disabilities. It's a lot of language and people have different definitions, so I'd like to start with a kind of a overall picture and then focus in on autism spectrum disorders. Some of these slides I credit to Dr. Matt Holder, who is involved with the Special Olympics as a medical advisor and works at the Lee Specialty Clinic, in fact, directs that clinic. So intellectual disability, we'll start there. It describes a person's IQ based on a standardized test, and it's around 70 or 75, which is quite low, but it limits a person's ability to function, their cognitive abilities. The standardized tests do separate conceptual versus social skills versus practical skills, but it's an overall perspective of the limitations that an individual might have to function within society, but also within our dental office. And here, this pyramid shows the breakdown of the population of individuals with intellectual disability. As you can see, the bottom of the pyramid here shows that the majority of individuals with intellectual disability have a mild form, and that's 2 standard deviations away from the mean population average. And as you go up the pyramid, you see that moderate to severe and then profound, it's a smaller percentage. And so this might say that if somebody has a diagnosis of intellectual disability, which formerly was known as mental retardation, the ICD-10 coding has updated the language because previously the language was not used properly and did not connote respect. So the proper language is an individual with intellectual disability. But the point I want to make here is that just because an individual has a diagnosis of intellectual disability does not mean that they would be within the moderate, severe, or profound. The majority of the time they'll be in a mild form of intellectual disability and would still be able to cooperate and understand and function within society, but also within our clinical practices. But it is a spectrum, and so each person needs a tailored approach. And particularly as we move up the pyramid, the approach needs to be tailored more and more. Here, this slide, lots of boxes here, but let's start at the center. This describes neurodevelopmental theory. So how does an individual end up with a certain condition? So neurodevelopmental theory says that either the environment or genetics has an impact on how a certain disorder comes to be. And it can have an impact on either the brain, the neural structures, or the body, as shown on the right. So if the brain is affected by a neurodevelopmental disorder, which more than likely than not, at least part of the brain is, you can have any one of those conditions, diagnoses on the left. You can have just one, or you can have multiple ones, and some individuals are more profoundly affected than others and have seizures and neuromuscular conditions. So moving to the right side of the slide here, a lot of our patients with intellectual or developmental disabilities also have abnormalities in the rest of their body, so heart conditions or neuromuscular conditions. So the point I want to make here also is that there is a pathway for neurodevelopmental disorders, and no matter how many diagnoses end up reflecting how their disorder manifests, the severity is what is important and what influences our treatment of the individual. So sometimes people come in with a laundry list of diagnoses, and it can be very intimidating, but it's always good to get to know the individual and understand how those diagnoses impact their life, their health, and the ability for them to be a dental patient in your office. Next, I want to demonstrate here the overlap and proportionality of different kinds of diagnoses, the 5 most common. And so within the all of the people who have developmental disabilities, which is about 5 to 7% of the population by most counts, 2.5% of the population have intellectual disability. So an intellectual disability is a developmental disability. And then 1 in 54 people, by some counts the CDC reports these days, will have autism. And as you can see, that overlaps. Autism is a developmental disability, and some people with autism, many of them have some form of intellectual disability. 1 in 333 individuals will have cerebral palsy within the population. And again, there's overlap. Some people can have cerebral palsy and autism and intellectual disability. 1 in about 690 individuals have Down syndrome. All of those people have some form of intellectual disability, and a few might have autism as well. 1 in about 2,000 have fetal alcohol syndrome. Again, the overlap to note. And then 1 in 3 or 4,000, depending on whether you're male or female, will have Fragile X syndrome. And so again, the complexity of the diagnostic overlap that an individual might present with makes us realize that a person with autism is different from any other person with autism, and we really need to approach each individual as an individual and tailor our approach to them. Here's just a slide from the CDC showing the increase in prevalence of children with autism over the years. And at present, the estimate is 1 in 54 individuals are affected with the spectrum. The Diagnostic and Statistic Manual of Mental Disorders has a criteria for diagnosing autism spectrum disorder. And here are some of the criteria described. Some of the early signs that parents oftentimes look in their children for an early diagnosis, as we know that early diagnosis and intervention are so important. But you can also see that the little person icon there, 46% of individuals with autism spectrum disorder are of average or above average IQ. So that correlates with the pyramid that we saw, that overall if someone has an intellectual disability, it's probably mild. And so when we think about bringing in an individual with some of these signs and manifestations of autism spectrum disorder characteristics into the dental setting, we begin to understand the challenges of providing optimal care to that individual. Most of our diagnostic information, of course, we have radiographs and a clinical exam, but a lot of it comes from the symptoms that an individual is having. And most of our treatment requires a patient's ability to communicate, and that's a two-way street, to receive information and to give us information. Also, sensory aversion is a huge challenge for autism, individuals affected by autism. And so all of our treatments, in fact, require some sounds and sensations that are not pleasant, and that creates some challenges. And that's why we're here today. I do want to note that the DSM criteria for diagnosis of ASD has a gradient. So depending on the supports that an individual requires, reflects on the level of their diagnosis. So this is also handy to have. Many times we don't get the level along with a health history. It just says the person has autism, but it's always nice to understand how does that impact their life and how might it impact their ability to receive care in our practice. There are many speculations as to how people develop autism spectrum disorder, and this image here, I'm not citing a very reputable source necessarily. This is just to illustrate that there are many speculations as to how autism develops in children. And the thing that I want to emphasize, though, is thinking back to neurodevelopmental theory, environment and genetics coming together to have an impact on the body and the brain. Autism is one of those neurodevelopmental disorders, and it really is a pathway of many different neurodevelopmental disorders. Autism kind of describes one maybe conglomeration of those disorders. And so for that reason, there really isn't a single diagnosis of autism. Every person with autism experiences it differently. And although the DSM-5 has criteria to describe this pathway or this conglomeration of disorders, it really isn't one condition such as hypertension or diabetes. And for that reason, an etiology or a cure would probably never be possible. I want to take a little bit of time here to talk about the social and political context that patients with autism are living in the reality of. And so some of you may be familiar with the medical model of disability versus the social model of disability. And throughout the years, the medical model has lost favor, and we've transitioned into the social model of understanding disability. And so some of you maybe aren't familiar. The medical model sees the person with a diagnosis as sort of the disease that we are treating. And so there are these problems and diagnoses that we are responding with either a cure or some kind of medical intervention. And so that was the era where if you had a disability, you likely were institutionalized and were treated for that disability, and your life kind of revolved around and you were defined by that disability. And now we have several pieces of legislation throughout the years. I think I have the Americans with Disabilities Act incorrectly dated. I believe it was 1990. But the Rehabilitation Act and then the Katie Beckett waiver, if you're not familiar, in 1982 was a young lady, a girl was born in Iowa, actually, close to where I did some of my residency training. And she spent the first couple of years of her life in the hospital because she had a very complex condition and needed a machine to help, I believe it was maybe to breathe, and a nurse needed to be there 24 hours a day to monitor those symptoms and vitals and operate that machine, piece of equipment that she needed. Her parents, of course, could have been trained to do the same thing that the nurse was doing, but the funding was not structured in a way where anybody would be reimbursed and the equipment would be paid for, except that she was in the hospital. So the Katie Beckett waiver allows individuals to receive funding to manage some of their conditions in the home setting, which is a huge deal for quality of life for people with complex conditions. Of course, the Americans with Disabilities Act requires dental offices to make sure that we're accessible to the public, including people with disabilities, and Senator Harkin of Iowa was a huge proponent of that, and disabilities advocate. The Olmstead Act of 1999 involved several women, I believe in Georgia, who wanted to live independently but had some form of disability, and it was ruled that they had the right to live in the community, and so this also shifts their services into the community, of course. And then lastly, I want to mention in relation to autism, the ABLE Act allows individuals with autism in particular to save funds that they earn through work and not lose some of their benefits as far as medical coverage and supports, so that they can work and live in the community and thrive. So as you can see, these pieces of legislation have moved us into an era where the social model of disability is predominant, where we see an individual who has barriers within society that need to be overcome by the society's structures. And so our dental offices structures needing to change, because now individuals with disabilities with autism are living in the community and have the right to access services in the community just as anybody else. So a little bit of some more social political context, but within the dental profession, I just wanted to note a few organizations that you might want to connect with if you're interested in this niche practice. Special Care Advocates in Dentistry is a very small organization, kind of a remnant of the medical model. They would have supported and still do support the few dentists that provide services within institutions. And that was a lovely way to provide care, team-based care with colleagues, medical colleagues, direct support professionals, everybody on site to provide optimal care to these individuals. But people are living in the community now. Many institutions have closed, and so other organizations have taken it upon themselves to equip the general public of providers in the community, not specialists and institutions, to also provide care to these populations. So the Special Care Dentistry Association has 3 councils: the Geriatric Dentistry Council, Dentistry for People with Disabilities, and Hospital Dentistry. So they do a lot of work to equip people in those 3 areas. And then an interdisciplinary organization that you may be aware of is the American Academy of Developmental Medicine and Dentistry. And I've listed small print, I apologize, but on the right side here, a few of their initiatives. And I've been involved with this organization a bit and was very excited to be part of some of these initiatives. I want to highlight one in particular, the Medically Underserved Population Initiative. So some of you working in public health might be aware that some populations are able to have a designation within either dental, mental health, or primary care as medically underserved. So these might be geographic designations. So physically there aren't enough providers in an area. And so that area is designated as underserved. And then facilities such as federally qualified health centers, Indian Health Service clinics would be designated as an underserved population facility. And populations, there are several: migrant farm workers, low-income adults, and Native Americans. And so the AADMD, I'll back up here, that would be the next slide. The benefits of this designation include HRSA primary care grants to provide direct services, and then training and recruitment grants. So I actually am a National Health Service Corps scholar, so I received a scholarship for my dental training, and I'm required to work in an underserved area providing care to underserved populations, and that's exactly what I wanted to do, and it was an easy way to recruit primary care providers to areas of need, and so that's what this designation allows. And then lastly, enhanced payments from the state and federal government. So the AADMD had a few initiatives to try to move this along for individuals with intellectual and developmental disabilities. In 2004, they had a task force on health disparities that used the criteria that is shown and starred here on slide 15 here, They have a very specific equation, and the ADMD used the data that is available, and unfortunately there isn't great data for this population of individuals with disabilities. But the data that was available, they were able to utilize and prove that according to HHS, the equation that they use, this population should be considered underserved. But it was a difficult time for the federal government then to extend this designation based on their equation. And they said it's not that simple and weren't able to accommodate that. Since then, there has been state-specific advocacy to see if various states would acknowledge this population as underserved and encourage better care. And the Student and Resident Committee of ADMD has taken this up to raise awareness within healthcare campuses. And every year they have an MUP initiative campaign. And so here there's a photo of me as a dental student getting signatures so people are aware and commit to advocating for better care for this population. We've also offered, as the ADM authored, several policy or position statements that have been co-signed by medical, dental, and public health organizations. And there is a piece of legislation, I'll go ahead and go here, that was introduced in July of 2018 to amend the Health Services Act, which would allow people with developmental disabilities to be considered an underserved population. Fortunately, there's been a lot going on in the federal government since then, so I'm not sure what the status is currently, but it would provide incentives for those of you who are interested in providing care to and access to this population. And I just wanted to note that the National Council on Disability recently in 2017 offered an issue brief in response to the data and experience of these individuals, in particular with access to dental care. And so they offered some critiques to dental education and the national professional organizations, principles of ethics and code of conduct, and offered some recommendations on how to amend the accreditation standards of our educational institutions and some funding mechanisms, including the reform of the Public Health Service Act, like I mentioned here. So let's pivot back to the clinical setting and talk a little bit about the importance of interprofessional care. And I start with drugs because the oral health conditions of individuals with autism are not necessarily different from that of neurotypical individuals. But some of the access issues, so the deterioration of their oral health because they cannot access timely care, that is a little bit different. And then also a lot of the medications that individuals with IDD are on will cause things like xerostomia, impairment in swallowing, and so that impairment in swallowing might cause aspiration pneumonia. And in fact, 1 in 4 individuals with IDD die of pneumonia. And so we know from the literature in long-term care settings, routine prophylaxis and more frequent oral prophylaxis, cleanings, prophies, is the only proven measure to reduce aspiration pneumonia in the elderly, and I suspect the same would be true for this population. And then bruxism is also a common thing we see in this population, and that can sometimes have is a side effect of some medications. So let's look at these numbers here quickly before we move on. 25% more likely to get a prescription, and I'll talk a little bit more in the further slides why that might be. But the key is that once somebody's on a medication with IDD, they are 3 times more likely to continue on that prescription. So they have drugs added on, and they're more likely to have a drug added on, but it's never discontinued. And so that increases the burden of those side effects, which have an impact on our oral health. 46% of psychotropic drugs don't necessarily have a corresponding psychiatric diagnosis, and that might be some off-label use of medications that are usually prescribed for a diagnosis, but are being utilized to manage either behaviors or other symptoms in these individuals, where it's sometimes hard to have a clean-cut diagnosis, as we saw through the overlap in diagnosis. And then lastly, 13% of anti-seizure drugs don't have a corresponding seizure diagnosis. And again, that might be some off-label use to manage behaviors. I want to spend a little bit of time maybe describing how some of those prescription practices happen. And this figure shows what would be called clinical dysfunction. And this concept of diagnostic overshadowing is important here. That is ascribing incorrect etiology to a behavior, explaining a certain behavior and not necessarily investigating to see what is the cause of it. And so if there's a behavior complaint, if somebody is being more violent to themselves or other people, the temptation sometimes is to just medicate that behavior. And then that behavior, of course, decreases, but we haven't solved the source of the problem. And so the behaviors increase. And again, you have a complaint and maybe another medication because, yeah, that would be the cycle. And so to make that a little bit more constructive, we can have an example here of oral health professionals being part of a functional clinical response. So if there's a behavioral complaint, we can identify the true cause of that behavior, which might be that they have abscessed teeth. And of course, it would be pretty outrageous, but it's not unheard of. I think some of us who are in the field of either elderly or treating people with disabilities, we know that sometimes the staff don't have high oral health literacy themselves and don't necessarily think to look in the mouth when there's a complaint of not eating or self-injury or just agitation, delirium in the case of dementia. And so we have this great opportunity to be part of the healthcare team to identify and treat the true cause of various behaviors, and then have a permanent solution for this individual that doesn't include an unnecessary medication. Just another example here of the bilateral benefits of interprofessional practice. Some of us have seen posterior enamel erosion, pitting of the cusps, and it's usually glassy smooth, not non-carious, and then the stair-step appearance of the amalgams. And that usually is a sign of some kind of acid attack on the teeth. And in this example here, a dentist can say, oh, this person has some kind of gastrointestinal issue that is causing their oral cavity to be more acidic, and collaborate with a gastroenterologist to look at the esophagus or the rest of the GI tract. And so in this example, we have, one of two options here, possibilities, probably more, but it could be something as severe as cancer that we are detecting and referring and collaborating to detect and treat. And then, of course, Barrett's esophagus, which could turn into cancer, but is treatable and is going to highly improve that person's quality of life. And other conditions that oral healthcare providers for neurotypical individuals, but especially for individuals who are either nonverbal or have challenges accessing care, dentists can identify diabetes, hypertension, uncontrolled conditions, cancers, and I think the next presentation today will be about syphilis. So interdisciplinary practice has benefits for the individual first and foremost, but for the healthcare team, both sides. I wanted to highlight, this is the clinic that I mentioned Dr. Matt Holder runs and is part of, and they sort of are a niche clinic in Louisville, Kentucky that provides care exclusively to individuals with IDD, and they have developmental dentistry. That's not a specialty necessarily, but they tailor their care and have behavioral analysts and occupational therapists. All these people come together and find a way to provide comprehensive, high-quality care to these individuals. So I would cite them as a success story and encourage you to look them up. I also want to include our direct support professionals as part of the healthcare team. Sometimes the people who care for people with autism or other disabilities and staff in nursing homes, those people don't get the credit that they deserve. And Dr. Rick Rader, another member of ADMD's board, he calls direct support professionals the linchpin to high quality care. And they really are our partners in understanding how to best provide dental care to an individual, how to tailor a home care routine, and if we have a good relationship with that care provider, then our treatment outcomes are guaranteed to be better. And so let's move on to the actual clinical dental strategies that I have learned and researched and would like to share with you today. I'd love to say that I could just wave a wand and turn you all into autism competent dentists, but it's not that simple. But I think there are a few pointers that I'd like to share with you that hopefully you will find helpful. And first, I want to say that I don't have all the answers, and I want to show you this Dunning-Kruger effect. Some of you may be familiar with it, of confidence and competence, the scale. And so as you can see the curve, sometimes if the less we know, the more we think we know everything. And as you start trying to develop your expertise in something, you realize that you have more questions than answers. But I want to assure you that that's a good place to be, because as you can see, the curve eventually goes up. But being of average competence is really all we can offer with all the questions, and having more questions is a sign of trying to provide optimal care. So just to say that having all the answers is probably not going to happen to very many of us, but having questions and tailoring our approach to each individual that we provide care to is a sign of our increased competence in this area. So I'll go over just some general pointers, and then just the key is cycling between training, obtaining more information and expertise from those who have done it longer than we have, and then applying those skills, those learnings is key to moving from not being an expert into actually being competent in providing care to individuals with autism or other disabilities. And then just the importance of seeking support, whether by other professionals, other clinicians, other professional organizations, educational opportunities, didactic or hands-on, and then advocacy. So realizing that there are some major political and financial barriers for this population, and connecting with people who can advocate on your behalf. So just some general pointers, starting slow. So that includes the number of patients that you might introduce into your practice with autism, but also with each patient in your care, starting slow, not pushing the issue, depending on whatever else happened in their week or day, how their other medications are being managed. It just might not work no matter what your approach is. That individual is just not going to be able to succeed in that particular dental visit. Tell, show, do, the technique we learned in our pediatric dentistry days in dental school, that works well for people who have some level of communication capability. So that might include showing images or some creative ways of communicating, but it oftentimes works best if an individual knows what to expect before something happens to them. The lack of control, like for any of us, is what causes challenges in dental treatment for individuals with autism. Desensitization is a technique where you might have an individual with autism come to your practice weeks before their actual dental visit where you expect to get anything done, such as an exam. And you have them look at the waiting room, maybe after hours or before hours if they're a morning person, and just familiarize themselves with the sights and smells, and of course the sounds of a dental practice. And then maybe the next time they'd come in and just walk in the hall down where the operatories are, and then the following visit, and you give them a mirror to take home, and they can practice having that put in their mouth by a caretaker. So basically eliminating some of the newness of each component of a dental experience that may be a trigger to an individual. And then eventually you might be able to get them in a dental chair and turn on the light, and that might be all you accomplish. But And this goes back to the funding mechanisms. There's not really anything to fund a desensitization visit, at least not to my awareness. But it's worthwhile if you're committing to providing comprehensive long-term care to an individual to develop that trust and familiarity with your office to make the actual treatment or exam a success. Sensory levels, so low sensory techniques include, of course, trying to use quieter devices, so maybe not the high volume suction, just the saliva ejector, maybe the slow speed versus the high speed because of the sounds. Of course, the slow speed is more bumpy, so maybe the high speed is better after all. Just finding what works for an individual if they do have that sensory aversion. And then high sensory techniques, it's kind of paradoxical, but some individuals with autism enjoy a heavy blanket or just a blanket to feel warm. I just treated a lady with autism the other day who was very much oppositional and opposed care, but once she had a blanket, she felt more comfortable. She had her beanie baby, and we were able to get through the treatment. And it seems like a very simple thing, but sometimes our lead aprons are very good, handy if you don't want to invest in a weighted blanket. So just finding the sensory stimuli that don't trigger them, but also give them comfort. Shifting our perspective in general from dental treatment, so diagnosing a tooth and treating a tooth, to treating an individual and contributing to the maintenance and improvement of their oral health. And that requires maybe our hygienists or public health professionals' expertise to focus on prevention and some very basic things like talking about their diet or their hygiene routines and finding a form that works for them to be able to improve the prognosis of any treatment that we are able to accomplish, however that gets done. And then lastly, just adapting. And this also, I'm not in a private practice, but we still have a team of dentists in our nonprofit practice, and a team of care coordinators and front desk staff, and everybody needs to be on board and adaptable when you provide care to individuals with autism. So sometimes, the person answering the phone, they may be a gatekeeper to your practice. And if a caregiver says, oh, my adult child has autism and they haven't done well with past dental visits and they've had to go to the hospital, that person answering the phone might just say, oh, this isn't the place for you. You should just call the university or something. But if you are willing to meet the person and start where they are and see what works, then that person answering the phone needs to be aware of that and be on board. It's a team effort, both your assistants and everybody from billing too, because there are a lot of challenges and everybody needs to be on board and supportive. And then lastly, I want to just mention there's a spectrum of sedation and sometimes a combination of options that works best for an individual. So I include music, toys, and sensory aids as part of sedation because it is anxiolytic to have a beanie baby that you can hold and squeeze when you're anxious. And then protective stabilization, I would say I should have included along with the kind of physical, non-medicinal forms of sedation. Some people really, with autism, really like having their arms secured by a Velcro butterfly wrap, they're called, or rainbow wrap. Some people may be very comforted by the stability of a papoose board, for example. And of course, there's political and social perspectives, and you have to collaborate with a caregiver to make sure that is something that they're on board with. And then pre-visit medications, so something like Ativan that will just help sedate them just a little bit so they're not as concerned if they've had past experiences in the dental office that weren't great. Nitrous oxide can oftentimes be used in combination with a pre-visit sedative, but I find that for adults, it tends not to work well, and for individuals with autism, sometimes having something additional on their face is not something that they would tolerate. And then, of course, the more heavy-duty sedation options, IV sedation, which could be done in an office either by a dentist who is trained and licensed or in collaboration with a nurse anesthetist or an anesthesiologist. And then general anesthesia, of course, in the hospital is an option, but I would say that should be avoided. And even if there are lots of urgent unmet needs that need to be dealt with in the operating room setting, it's not a once and forever that person needs to be in the hospital operating room setting. It's always nice to be able to scale back and try to at least offer more frequent cleanings or just visits for minor treatments, fluoride applications, or small restorations after those the initial burden of unmet needs is met. And I just want to make a note about guardianship. Many individuals with autism will have somebody else making decisions for them, and there's a lot of paperwork that both financial and with guardians that we have to be aware of. But seeing them as a champion, somebody, a partner that helps you be able to provide your care, but also ensure that the care that you provide will be taken care of by somebody at home, and that there's a long-term relationship with that individual within your dental home. Guardians can sometimes be your biggest advocates or a challenge to providing the care that you feel is best. A few training opportunities that I want to make note about include the program that I was a part of. I completed a master's in dental public health and this certificate in geriatric and special needs dentistry at the University of Iowa. And I think it provided a very solid behavioral management, experiential training experience. And the emphasis there was not on sedation. It was mostly on outpatient care, which is the hard stuff. It's not very difficult to go into the operating room setting and have work on somebody's teeth who doesn't need much behavioral management. The Lee Specialty Clinic has a mini residency, which might be of interest to practicing clinicians who can't take a whole year or more out of their careers. This is a 1-week program that can give you kind of a taste and some best practices and show you the success of this interdisciplinary model of care. And they also have an AEGD where I think it's one of the only ones in the US where they treat 100% of their patients are people with disabilities. And then, of course, there's some didactic resources by the Special Care Dentistry Association. Many conferences these days are going virtual, so there's a lot of resources online that you can access to further your knowledge on this topic. One other resource I want to make note of is Practice Without Pressure. You can see the smaller image of a woman, and that is her son. And she developed this program because her son, she realized, was larger than what she could sort of hold down during any sort of medical procedure or dental visit. And she has created a multidisciplinary approach to having an individual sort of be a co-facilitator or guide at dental or other medical visits. And so I encourage you to research that if you'd like to go the minimally invasive, minimally less sedation approach. And then lastly, just create your own resources. This is a resource that I created in collaboration with a group home, an organization that supported and trained and staffed group homes with caregivers. And I asked them, what's it like for you as a direct support professional to take an individual with moderate or severe disability to a dental visit? What are your biggest challenges? What do you wish the clinician would know? And so we have, what we came up with is twofold here. The in-office communication strategies, which would help both the clinician and a caretaker or whoever is accompanying that person to the dental visit understand what are the best ways to communicate with this individual, what are some of the triggers that might cause a visit to finish very quickly, or some of the things that would be reassuring to the individual. And then on the flip side, what are some at-home care strategies that the clinician recommends and wants to make sure that everybody's on the same page following through as caretakers go on shift and off shift and change and move. There's high turnover in that field. So we created it and it was a great idea. I don't know how much implementation since I left the residency program in Iowa City has followed, but this is just an example to say that you can create your own resources as the need arises, and that emerges because you ask questions and you think about how can this be better. And this is just an example of visual narratives or visual schedules where you can point to the pictures to especially either nonverbal individuals with autism or those who have trouble communicating or don't communicate using words, but usually can understand images a lot better. And so this kind of social story that describes a dental visit will, and if they review that with a caregiver prior to coming to the dental office, it might make them less apprehensive as to what is going on. So I hope that I've provided some encouragement as you consider providing care or already providing care to adults or children with autism. And I hope you're not disappointed that there's not just one silver bullet or that I've just magically made you into autism competent providers, but it is a journey, and I'm very excited to have so many colleagues along with me on that journey. And I'm finished with my presentation. I think Christina may facilitate some discussion and maybe some question and answer.
Well, thank you, Dr. Slashcheva. I really enjoyed hearing about the wider range of dental considerations when caring for patients with autism. I have several questions in the Q&A box. One of the questions was, when should hospital treatment be considered?
I think when there is emergent need and it cannot be delivered in an outpatient setting. So in my practice at Apple Tree, we contract with a nurse anesthetist that comes into our clinic. And we also work with our mobile program in group homes. So we are able to follow up with those individuals with more frequent cleanings. And then we realize that we can only do so much as far as treatment is concerned in that outpatient setting. So maybe every year or every 2 years or every 3 years, depending on the individual, we'll bring them in to the IV sedation program and get a really nice set of x-rays, deliver any kind of restorative care that's necessary, or if there's any emergent extractions that need to be completed. And so I see it as kind of like a service, I guess, that you offer, and then you maintain in between those more intensive treatment settings. And so some people are not candidates for that low intensity sedation, IV sedation, and so general anesthesia would be appropriate. Hope that helps. But to me, I would rather put forth the effort to try to do a more low intensity sedation for an individual before. And the other thing about hospital dentistry is that usually there's about a 2-year wait list at least. And usually people have to travel to an urban center. And that's not always possible for the complex lives of these individuals because oral health is not necessarily the most high on their list of priorities of everything that they're managing.
Thank you. The next question, you did discuss guardianship, but there was a question about, can you please talk more about what is the actual impact of guardianship on treatment?
It can be varied. It depends on the relationship of the caregiver. Sorry, I might have skipped out there for a second. It depends on the relationship of the caregiver to the individual. Sometimes these are relatives, more than likely they are either parents or siblings. Sometimes they're state appointed guardians and they don't necessarily know the individual as well. And so the clinician has to sort of educate and collaborate with the direct support professionals who are with that individual on a day-to-day basis to relay to that guardian. And sometimes even parents or siblings don't necessarily live with an individual if they're living in the community in a group home. And so the effect of guardianship is basically adding complexity and time to a clinician to describe the experience of whatever clinical situation is going on to that guardian. to educate them about the impact of that oral condition on the individual's life, and to describe the treatment options just like we would to any patient, and the benefits and drawbacks. And it's challenging because that guardian is likely not disabled and cannot maybe understand why, from our perspective, this option would be better than the other option. I think we run into this a lot, both with individuals with disabilities and long-term care residents, that, you know, the guardian really wants that front tooth fixed, but the individual does not care about that front tooth. So sometimes it can facilitate treatment acceptance, and sometimes it can make things a little bit more complicated, including neglect, where we have recommended the removal, for example, of an infected root tip, and it has not happened time and time again. And we feel that, you know, if it was a gangrenous toe, it would probably be removed, but it's a tooth, out of sight, out of mind. Nobody really thinks about it. So it's mixed. It's complex, makes treatment not quite as straightforward.
Thank you. You mentioned several training opportunities. Is there, for special needs dentistry, is there an online training or program that providers may have access to?
I mentioned one through the Special Care Dentistry Association that I think it's a 10-hour CE course. I believe that's what it is. And that provides kind of a very good foundational overview. Yeah, 16-hour, it says. Great. So it's 16 hours, which is great for CE, but it also just provides a very broad overview and some very specific clinical material, dental materials, clinical strategies for people with special needs, and I think they include maybe geriatric patients in that. Yeah, I'm not familiar of any online programs like a residency online, but there's always Google. I think it's hard to replace that hands-on, being able to watch an expert manage and treat an individual with a disability. It's hard to replace that hands-on observation and then implementing those skills.
Thank you. Someone asked about an abbreviation or an acronym on one of the slides, FXS. Can you explain that?
Sure, that was early on in the presentation, the proportionality of the 4 or 5 or 6 main diagnoses of developmental disabilities. That was Fragile X syndrome, and there's about 1 in 3,000 to 4,000 in the population with this condition, depending on if you're male or female. It's an abnormality on the X chromosome. Has some very characteristic manifestations as far as health and behavior.
Okay, thank you. Can you talk more about what clinical procedures or treatments work best for patients with autism?
Sure. So I didn't go into great depth describing the particular clinical techniques or materials in this presentation, because I wanted to provide an overview, and I wanted you to recognize that it's learning what works in your hands. As we all know, dentists prefer their particular instrument or their particular dental material, and then adapting based on the individual's needs. That was my hope to emphasize. But I have found in our practice that some preventive strategies that work really well, preventive materials, fluorides, so whether it's Prevident toothpaste, high concentration fluoride toothpaste, or chlorhexidine mouth rinse if they've got gingival concerns, just an aversion to the bubbles or the taste of toothpaste, then dipping a toothbrush into chlorhexidine mouth rinse, or even Listerine Total Care, which has fluoride and antimicrobial properties. If they can tolerate the mouth rinse better than the toothpaste, then just go ahead and use that on an ongoing at-home basis. And then silver diamine fluoride, many of you are probably aware of its, it's used as a desensitizing agent, but it can also be used in children and older adults and adults across the spectrum to arrest early carious lesions. And that works pretty well for somebody. It takes about a minute or less to apply if you're coating it with fluoride over top. That can avoid having to have the patient be numbed and drilled on the tooth, and it can sort of prolong their tenure as a patient in an outpatient setting before they need to go into the operating room. And it's an early intervention technique. You know, I always tell people, we can just wait for this lesion to get larger, or we can do something about it, and here are the options. SDF, it does stain the teeth, so that's a consideration for guardians and something to educate them about. But it also can arrest the decay and or slow down its progression. And then lastly, minimally invasive techniques. So glass ionomer, cements, and restorations are becoming, getting a little bit more spotlight now with the pandemic, where we're not supposed to excavate as much decay with high-speed hand pieces. And so glass ionomers are great because they release fluoride into the tooth, and then they recharge fluoride from toothpaste or mouth rinse, and then release it into the tooth again to reduce the incidence of recurrent decay. So those are a couple of things that I would note as far as dental materials and minimally invasive techniques.
Well, thank you. That's all the time we have for questions, but you can all contact Dr. Slashcheva for any follow-up questions. Thank you, Dr. Slashcheva, for that wonderful presentation.
My pleasure.
Yes, thank you, Dr. Slashcheva, and for a wonderful and informative presentation. And thank you, Dr. Murphy, for serving as moderator for today's presentation. Thank you again, presenters and moderators, and thank you, audience, for joining us today.